So we are doing the laser lab talk, and we'll have some fun history. We're going to talk through kind of the three most common lasers that are performed: YAGs, SLTs, LPIs. And I think a timely lecture, given the expansion of scope here in Montana, because these are things that historically I was doing, that more of you will be doing. And certainly Travis, Sierra, Alicia here will be kind of transitioning after their training at the end of October to taking over most of these things for our practice. But just thought it'd be worth highlighting also some unique cases, particularly in the world of YAGs that people may or may not have seen. Does anyone know what this is a picture of, and or when the YAG laser was first developed? I didn't know, so that's why I put the slide in. This is Bell Labs. So this is where the first YAG laser was actually developed in 1964. Fun fact. So they've been around for a long time. Sometimes patients ask, well, how long has this laser been around? So it has been around for over 60 years, and iterations of it continue to evolve, obviously. So when we're talking about YAGs, I always like to remind patients, the best, I think, education about a YAG is talking about a YAG during the cataract eval, so that they're aware that this is a potential thing that they're going to have to deal with weeks to months to years after surgery. And so basically every patient that comes in for a cataract eval, we're kind of proactively talking about the potential that they could need a YAG, and that when we take out the cataract, when we make an opening in the anterior capsule of about 5.5 to 6 millimeters, some of those residual epithelial cells that line that capsule can proliferate after surgery. And so even though we put an implant in, even though those implants now have a square posterior edge that's less likely to develop PCO than earlier iterations of our lenses, we can still see proliferation and migration of those lens epithelial cells posteriorly, in leading to what we all commonly see as posterior capsular opacification, or PCO. And again, this can be mild, this can be moderate, it can be significant. But if it's impacting patients' vision, it's obviously something that we want to think about and talk about. So, Brooke, I'm going to throw this to you as Ms. Peacock first. When you're seeing a patient that's being referred in for PCO or for a possible YAG, I'm just curious kind of what things you're thinking about, what things you might also be looking at besides PCO that might affect your decision for taking care of a patient.
Yeah, so first we'll want to find out their complaints, make sure it's warranted to actually do the procedure. So I'll ask about nighttime driving, other dim lighting and dim lighting conditions that may cause like a smearing in their vision, especially when patients say, oh, my vision was better after cataract surgery, I thought it was great, and now I'm not sure that I'm seeing as well. To me, that's kind of an obvious change in their capsular opacity. But on the evaluation, I certainly want to make sure that their dilation gets large enough. So I'd really like to see their pupil get past the capsular rhexis, because then I know that Dr. Greenwood is going to have a really clear view to the back to make sure that he can get a nice wide opening there with the laser. I'm also looking inside the eye just to make sure that there's no reason I can't do it. So I'd be looking for inflammation, maybe some retina findings, anything that would maybe cause some disruption or tugging on the vitreous that could cause some issues with the retina. So basically in the back of the eye, I just want to see a stable eye that we saw, before cataract surgery, and then checking for anything related to potential retinal complications or inflammation.
Nice. And Travis, can you talk just a little bit, when you're seeing these patients, sometimes we'll see early PCO. So sometimes a patient maybe has a PSC cataract. We go to remove the cataract, we go to try to polish the posterior capsule, and they have fibrosis of the posterior capsule. Most commonly seen if they've had a previous retinal detachment, but maybe they've had multiple injections. If you're seeing early PCO, even at a week or a month, what are you talking to those patients about, and why do we sometimes say, hey, let's delay this just a little bit, even though it might be visually significant sooner?
Yeah, for those patients at risk, those, like to your point, like the best time to talk about PCO and the potential for a YAG is during the cataract evaluation. I kind of set them up as, again, cataract step 1, potential for a YAG is step 2, glasses or laser fine-tuned depending on what lens option they go with. And that it's common, as we kind of talked about, I kind of quote 60 to 70% of patients will need a YAG at some point in time, and tell them that typically for the vast majority of patients, we like to wait 3 months to make sure that the lens itself is stable, that prematurely going in and removing that PCO, opening up that posterior capsule has a potential to cause a little bit of a lens shift, prescription shift. And so for patients where I see and occasionally have them in for a week and I see a little bit of capsular haze, visually significant or not, I start talking about at that point and tell them, especially for patients that have gone with an upgraded lens, their expectation of vision for where it should be 1 day, 1 week, 1 month, start having that conversation to say, this is one thing that I'm seeing that has the potential to be impacting your vision or keeping things from being as sharp or adding to your nighttime vision issues that we'll continue to monitor through. It doesn't require any treatment at this point, but definitely maybe something in our back pocket when we hit that 3-month mark.
Perfect. And I think the other thing just on this slide to mention, CME is a big thing for these patients. So, a lot of times these patients are getting an OCT just to rule out CME. Because again, cystoid macular edema post-cataract surgery can kind of show up at a similar time of PCO. And so particularly if you have a patient who's like, gosh, their vision's 20/50 or 20/60, but they have mild PCO, you're like, that doesn't seem like a 4 or 5 line drop worth of PCO. Getting an OCT can be really helpful in making sure that we're pre-treating that. And I'd say the most complicated patients are, maybe a diabetic patient has chronic small cystic macular edema that they were cleared by retina prior to surgery. They still have a little cystoid macular edema. Usually if it's stable and it's been long-standing and they've been kind of cleared by retina, we'll go ahead and move through with the PCO treatment with a YAG, but we will tell them, hey, we do want this rechecked, in the next couple of weeks to month, just to make sure that CME isn't worsening post-YAG. It's unusual with low-power YAGs that we use right now, but still something to be considered. For our practice, and certainly if practices are moving into doing YAGs, one of the, I think, the very helpful things, both for our team and patients, and then as it relates to insurance coverage, we have this pre-YAG capsulotomy YAG or patient questionnaire, and it's basically looking at kind of symptoms of fluctuating vision or other symptoms that a patient might have that they can just go through while they're kind of in our atrium area to kind of check box, yes or no, or are these things affecting? And the reason that becomes important is if we're doing what we would term a medical YAG, meaning a YAG that meets criteria by insurance to be covered by insurance, the patient not only has to have PCO that we visually see, but they need to have a complaint or a symptom of it. The insurance is not going to allow us to do a YAG if the patient's not bothered with regards to their vision. So documenting that either in an HPI section and or in a scanned-in questionnaire is an easy way to do that. And then for most insurers, kind of the standard rule of thumb is 20/30 or worse, or honestly more commonly, glare demonstration by BAT, brightness acuity testing, loss of 2 lines or worse. So it's not uncommon. We may have a patient with significant nighttime glare, maybe they're 20/20 minus, 20/25 plus, but their brightness acuity test drops them to 20/40 or 20/60, and that still is medically indicated to be done, but you just have to have documentation of that brightness acuity testing. I'll throw this one to you, Sierra. When you're talking to patients about risks of the procedure, kind of what to expect, how does your conversation go with a patient who's had cataract surgery with you? You talked to them about doing a YAG previously, now they're back and they're ready to have the YAG. What things are you generally going over with them?
Typically just, I tell patients it's one of the, this is probably to quote you, quickest, easiest, lowest risk things that we can do, but that we don't get to claim 0 risk on anything. And so, I tell them, as listed on here, today is going to be blurry because we've picked on you a lot with drops and scans, and by tomorrow you should already be functioning back to normal pretty well as long as the dilation's worn off. I warn them about floaters, that they'll likely see some floaters for a few days or a week after the procedure, not to worry about those, but that's just remnants of the capsule. That's kind of the main thing. I mean, obviously there's other things listed, but those are the main ones that I talk patients through. And then depending if they have, CME or things like that, then we'll talk through that a little bit more too.
Nick, anything else you add to that conversation?
I was thinking about something completely different on the next slide, so I didn't hear the question.
I
I need you to say it again.
No, well, wait, you get the next slide.
I have one thing that
Yeah,
I would
go
add.
for it.
I tell patients it's low risk, not 0 risk. So things to look out for: darkening, curtaining in the vision, tons of flashing lights, or tons of new floaters, that it's being swarmed by bugs everywhere. Some floaters is okay for a week or 2, but if you have any of those signs and symptoms, to either see us or their primary optometrist right away.
Yeah, and I think, fortunately, most patients, not all patients, most patients who have had are undergoing a YAG oftentimes already have a PVD. But certainly if we have an OCT and we see, gosh, this patient does not have a PVD, there is, a theoretical risk there. So again, if they were to develop a new PVD, understanding those symptoms and being seen does become important.
I think I go through every patient. I tell them there's risk for swelling or inflammation in the back of the eye, and there's risk for retinal tear detachment. I tell them these are the same risks that you took on when we did your cataract surgery. They're cataract surgery, I kind of quote ballpark about 1 in 10,000 for a post-YAG, depending on axial length and a few other components there. I probably quote it closer to 1 in 20,000 as far as the potential for those, but I quote them every time and then tell patients, about 20% of patients will notice some floaters, can linger for a few weeks, but potentially be stubborn and hang out for a few months.
Nick, is he right?
Yeah, I agree.
All right, Nick, here's your slide. I don't know what you wanted to say about it, but take it away, my friend.
No, I couldn't read it, and that's why I was sitting here trying to see what the next slide was going to say. So I'm back on. I'm paying attention. I'm ready for your next question.
Yeah, we need to actually hide the next slide for this one because it's going to have all the answers when we get to the cases, and that'll be just way more fun. I'm just joking. It's just fine right now. Contraindications. The one thing, active inflammation, obviously, or infection, but active intraocular inflammation is a contraindication, and corneal edema where you can't actually get a good view. Interestingly, most small corneal scars you can usually YAG through, and particularly if you use like a contact lens, you can usually get through those actually quite well. So even if a patient has a small anterior stromal scar, even by increasing the energy and just going right adjacent to the scar, you can usually treat a PCO just fine without having to worry about that. So contraindications and cautions, unstable intraocular lens. Sarah, do you want to talk about my most embarrassing YAG that I've ever done?
Do you want me to?
No, I'll take it. So we're going to have some slides at the end. The most embarrassing thing that I've ever done with a YAG, and you're going to be like, I can't believe you actually did this, but we had a patient with a 3-piece IOL. A 3-piece IOL is an indication that maybe there were some complications with their surgery, unless that's the common lens that somebody uses for that. But for a lot of surgeons, that's sort of a backup lens. And we had a patient who was like 20, 25, but had this central, 2020, 2025, had some glare and had this strand of capsule that just went right through their center of their lens posteriorly and was really bothered by it. And I was like, we saw him like, well, vision's pretty good, but you have some glare. We can go ahead and just do that. We'll just hit that with the laser, no problem. And YAG it, just actually only took one spot. And the little capsular remnant just popped. That was great. I was like, wow, that was awesome. And then the lens just fell backwards as I was watching it. And it went from 20/20 to hand motion immediately. And I've never been so devastated by any of my YAGs before. And so I just say that, again, it is way, way uncommon to have an unstable lens, but it is very helpful to know their surgical history. And if they have a decentered lens or just an atypical appearing lens, it is worth a conversation with the surgeon. Because again, that's a bummer. This was like the nicest guy ever, and he's so happy that I put a secondary IOL and got him his vision back. And I was like, well, that's very nice of you. That was excellent. So, but don't advise that for what it's worth.
Where would you tie in, as far as unstable lens, pseudophacodenesis?
Yeah, so pseudophacodenesis, or like the lens or capsular bag complex after actually having some movement, again, typically a sign of zonular instability. But in that case, I still am okay doing an opening because, again, that's a sign that the whole zonular capsular complex is a little bit looser. Maybe they had pseudoexfoliation or otherwise. But making a small posterior capsular opacification is still fine. The bigger concern is, again, a lens that's not fully secured or adherent in the capsule bag because they had a posterior capsule tear with surgery or something else.
How small would you say is too small for pupillary dilation? Because I don't know. I mean, I don't know that you've ever sent one back down saying you won't do it or can't do it.
Yeah, I mean, there's different thoughts even about how big the YAG opening should be, whether it's 3 millimeters, 4 millimeters, 5 millimeters. But again, I think if you can, in essence, if you can clear their scotopic pupil size, then they're going to be really happy. So that, to me, is the bigger thing. And again, somebody who's a poor dilator, they're also a poor dilator when it comes to scotopic light settings. So even just clearing their central visual axis in that setting is a very nice thing. Okay, so nerd a lot. This is a question, actually, first one person to get it. I have a Starbucks gift card in my bag for the first panelist who can tell me what an ND YAG, what that stands for. I get this asked all the time, and I almost butcher it 80% of the time.
YAG is iridium aluminum garnet.
Ooh, I'll give you a gift card just for that. Way to go. Beautiful. Yeah, so there you go. They love to know that it's a iridium aluminum garnet laser, and especially if you work here in Bozeman where there's like 7 laser companies, they're all super interested in knowing exactly what type of laser you're using to laser their eye, which is fun. And the wavelength is 1064, which occasionally a patient will be really interested in knowing, so I have to constantly remind myself what it is, because otherwise I'll forget, and they'll ask me, and I'll feel like, oh, I should still know that. With regards to the procedure itself, I'm curious, show of hands, how many people have actually watched or seen a YAG ever be performed? Raise your hand super high so I can see. Okay, a decent number of people have. Again, as described by Sarah, I do tell patients, this is the easiest, simplest procedure that we do in eye care. It's gonna take about 10 to 15 seconds to do. There's no pain. There's typically no drops afterwards. There's no restrictions in their activities. With this, I'll usually set our power, typically for me is like 3 to 3.6 is usually average. Sometimes we'll have to increase that millijoule amount if they have a really thick posterior capsule opacification. And then we'll usually do what's termed a posterior offset. So the energy of a modern laser, you can now actually offset anteriorly or posteriorly. But the idea is you have focusing beams that allow you to focus on the posterior capsule, but while you're focused on the posterior capsule, the laser is actually going to deliver the energy 200 microns posterior to that. And the idea is trying to prevent or decrease the risk of developing an IOL pitting. So that's a nice feature that many of them have, and oftentimes is adjustable on the amount. The pattern of capsulotomy, I think, is independent of doctor preference. Lots of people have different thoughts on it. A cruciate would be like a classic kind of cross pattern, and we'll see an example of that. And then you can also do a circular, and there's variations of that. I personally prefer a circular pattern, and the reason that I prefer that is every time that I'm delivering energy, it's outside of their center of their lens. And so if by happenstance the patient did move, blink, shift, or otherwise, and they were to get a small pit, it's hopefully not going to be dead center in the center of their lens, which is kind of a bummer. So again, if a patient has real difficulties with positioning, you can have a team member that can kind of help hold their chin and head in place. That's typically not needed. You can use a contact lens. This is a nice masking agent, as I talked about with like small stromal scars, it's great, but also if they have like diffuse 3+ punctate dryness, because we put proparacaine in their eye and then they left their eye open for the last 20 minutes. It's a good way to mask that dryness and still be able to deliver the energy really nicely. And then if you're getting a laser, you might get just a YAG laser, you might get just an SLT laser, you might get a combo SLT YAG laser. If you get a combo YAG SLT laser, which is what we have, just make sure it's not on SLT mode when you're doing a YAG, because an SLT will deliver the energy until it hits the first pigmented tissue. And so if you are on SLT mode, trying to do a YAG, it will hit the retina, and that's not a great thing, particularly if they're looking straight at the light. So again, classic example, posterior capsule opacification, 2 examples on the left, kind of a classic diamond opening with a YAG afterwards. Now, I thought what would be fun would be just to run through some wildly unusual cases that don't often come up. I've seen all of these, and so I think they're just fun to kind of be aware of, because they're sort of the unicorns of posterior capsule opacification or otherwise, or the unicorns of YAGs, and it's worth knowing about, because sometimes otherwise it's a little bit confusing. So first one, this is a patient who had cataract surgery, actually about a week and a half ago. And they called back in and they said, man, my vision is just totally foggy. It just went totally white, like I can't see anything. And you're like, well, it's probably just a little dryness, put some tears in. They're like, no, it is really blurry. And you're like, okay, come on in. And they come in and you dilate them and you're like, whoa, what is going on? And they don't have a hypopyon, they don't have any inflammation, but their lens looks totally white. But when you look at the slit lamp, the whiteness is all accumulated behind the lens. This is an anterior segment OCT that actually shows a picture of it. But you have this accumulation of opaque fluid behind the lens. Brooke, I'm going to throw this wild curveball to you and see if you've ever seen this or know what this is. That's kind of unfair, but...
I've seen this twice.
Oh, there you go.
This is capsular distension syndrome. where fluid gets trapped behind the lens. Possible risks are from like excessive force or pressure used with the hydrodissection of the lens or something like that. Small association with P. acnes bacteria. So most of the time it's nothing, it's just like turbid fluid and you can open it with a YAG. Low risk of endophthalmitis.
Yeah. And usually the endophthalmitis will have like focal, like if it is P. acnes, it'll usually have like focal spots that you'll be able to see.
Oh, like
and that can even be
colonies
more
of
chronic.
bacteria
Yes.
or something?
Yeah.
Okay.
But if it's acute like this and it's diffuse like this, you're exactly right. It's capsular distension syndrome and opacification or murky fluid accumulation behind the capsule can also have some retained viscoelastic that is in it and is the absolute most fun YAG in the whole world to do. Because you do one YAG and then you just see this milky fluid just go right back into the vitreous, which is so fun. And you're like their hero, although they're kind of mad because they, got real blurry, but they really can see instantaneously a lot better. And they might see, this is one where their vision might be blurred for a day or two as that just gradually gets absorbed by the body. But again, A and B, pre-YAG, post-YAG of a patient that had capsular distension syndrome. So kind of a unicorn, but if you ever see it, I've seen 2 cases while I've been here in Montana, and it is quite alarming the first time you see it. But again, the big thing I think just looking at is making sure, hey, is their AC quiet? They're almost universally, their anterior chamber is totally quiet. That's non-infectious, but their vision is super, super blurry.
So with that case, how soon after cataract surgery was that?
That one was like a week. And these are ones I would instantly YAG.
Okay. So
Yeah, you don't let them stay hand motion for the next 3 months saying, we're just going to give it a little time.
Let it settle.
Yeah, they get an instant YAG and they're instantly much happier. So yeah, good question. Okay, so YAGs, what could possibly go wrong? We just said it's like the easiest thing in eye care to do. So that sounds fun. What could possibly go wrong? Okay, we're going to start with this one. Nick, what are we looking at here?
Those look like some IOL pits, I think.
Yes, those are IOL pits. So IOL pits, I'm curious, show of hands, how many people have seen IOL pits on an IOL? Yep. You will definitely see them in your career. So the right picture is a great example of somebody who had this beautiful cruciate pattern YAG capsulotomy, and they just went straight vertical, and then they went straight horizontal, and they pitted kind of all the way through that. And then the left one, a little bit more variable. Again, the goal with a low-powered laser with a posterior capsule offset is that you're hopefully avoiding that. I will say there are certain lenses that are far more common to IOL pitting, and if you're jumping into the YAG game, it's worth knowing that because these are lenses that you may offset do your posterior offset further or lower your energy level. So the 2 biggest culprits to that are any silicone-based IOL. The most common silicone-based IOL that we currently use is the light adjustable lens, which has a silicone monomer. But there are also some silicone lenses that are commonly inserted as a 3-piece lens by some surgeons. And then the other one is any hydrophilic acrylic lens. So most common 1-piece lenses used in the United States are hydrophobic acrylic. The most common Johnson & Johnson lens, Alcon lenses are hydrophobic. There are some hydrophilic acrylic lenses, and again, they're just a little bit more prone to pitting. If there's good news, actually, usually these, if you ever see a lens pit happen when you're doing a YAG, it's like, ooh, and it'll actually usually shrink in size with time. And interesting, a lot like asteroid, visually is often not super significant for patients. So oftentimes, even though, like this patient on the right in particular, or left in particular as you're looking at it, might not even visually notice those pits, even though you would think that they would. Similar to many of our patients who have asteroid hyalosis all throughout their vitreous, but the shadowing effect that they get from a very small imperfection like that, usually not bothersome. Sometimes can be, in which case we could talk about an IOL exchange, but that's not fun after someone's had a YAG. Okay, let's see. Who wants this one? This is a really hard one. I almost feel bad, Alicia, but I'm going to ask you. Okay, so this is a patient who was sent in for a YAG, and had a beautiful YAG. This was not one of my patients, but had a beautiful YAG, went great, and then they called back a month later, and they're like, my vision was better, but now it's a lot worse. And they have a history of asteroid hyalosis, and they're like, oh, you just seen your floaters? Like, no, this is very different than my floaters. And when you look at it, they have this kind of reopacification right on the posterior aspect of their lens. Any idea what's going on here? It's okay if you don't. This is very atypical to see.
I believe it's a reaction of the asteroid with the lens itself. It creates these crystalline white opacities on the back of the eye. The name, I don't know.
No name needed. Way to go. So this is actually a pretty well-described phenomenon where you'll get calcification of a silicone-based IOL post-YAG interacting with asteroid. So asteroid plus a silicone IOL that's had a YAG is not always, but very commonly can lead to calcification of the posterior aspect of the lens. This is a non-YAGable problem. You cannot YAG that off of the lens. It's impregnated onto the posterior surface of the lens, and so this is a lens that has to be explanted and a new lens put in if this were to happen. So again, it's actually one of the reasons that silicone lenses as a whole have kind of more commonly become less common in the United States, just because of this theoretical risk. So, nice work.
Are all 3 pieces silicone?
All 3 pieces are not silicone. Yeah, that's a great question.
So there are options to do a...
Yes, all silicone lenses have to be 3-piece because a silicone haptic is too mushy, is too soft to actually hold itself in the capsular bag, and they would find most around it. So all silicone lenses are 3-piece, typically. But you can have a hydrophilic 3-piece lens, a hydrophobic acrylic 3-piece lens, or a silicone, or a PMMA.
So then, because they wouldn't have the capsule anymore, so you do a sclerally fixated exchange here?
Yeah, good question. So if this patient had then needed an exchange, if they still had a beautiful anterior capsule, you could theoretically exchange this lens, put the new lens in the sulcus, and even do an optic capture. So the haptics would be in the sulcus. The optic you would dunk behind the anterior capsule if you still could, and they'd do really well. If their capsule support was just totally missing, then you could also do a secondary IOL. But most commonly, this would be a patient that you could take the lens out, put a new lens in the sulcus, and they'd still do quite well afterwards. Anyone seen this before? Just out of curiosity. Show of hands. One person. Okay, yeah. Uncommon, but worth knowing. Okay, this one. I'm going to give this one to the combo of Travis and Alicia. Travis and Sierra. So this is a patient who had cataract surgery, had a history of a retinal detachment, had a history of glaucoma surgery, cornea decompensated, then they underwent a DSEC. They had a DSEC, the cornea cleared up beautifully, but their vision just never cleared up. And their lens, again, looks cloudy, and they were sent in for a YAG because they have a cloudy IOL. But when you're looking at it, it almost looks like the anterior surface of the IOL is cloudy. What say you?
I'll pass this to Sierra.
No, your mic's not working? Okay. Mic's not working. That's okay. Yeah. This is like a super rare thing to see, but it's also another one worth noting. This has been described with silicone lenses. It has been described with hydrophobic acrylic lenses, but it's been very well described with hydrophilic acrylic lenses. And this is a calcification of a hydrophilic lens in association with intraocular gas. And we actually see it in 2 situations. So we see it in patients who've had a YAG already done, and they have a pars plana vitrectomy, and then they get gas put into their posterior chamber, and it interacts with the hydrophilic acrylic lens, most commonly causing calcification or opacification, so then it looks like it's on the posterior surface. Or patients who have had a partial thickness cornea transplant on the front, and so again, the front part of their IOL, if you look at the IOL, one of the unique things you'll see, the calcification is 100% just right where the open capsule was. The peripheral part of the lens that didn't interact with the air bubble is totally clear. So it's a really kind of unusual pattern, and the same oftentimes we'll see with a silicone lens in asteroid, that sometimes it'll interact with the whole lens. But this is very specific. You'll see it just exposed to the area of exposure of the gas, which is kind of an interesting one. Okay, this one. I remember being in the pathology lab in Utah when this lens got sent in, and my nerdy professor, who was maybe Professor Plum, was just like so unusually excited to see this. This is actually a glass IOL that was yagged. So back in the 1980s, there was a company that actually made IOLs that were made of glass. And they had this PMMA haptic design, and then the optic would sit into it. And turns out it was actually a totally fine lens, and then the YAG laser was brought to market. And the first time somebody yagged one of these, they realized that was not a really good idea because it shatters literally in the eye when you yag it. So if you ever were to see just a really, really weird haptic design on a patient that had surgery many, many, many moons ago, it's just worth making sure that that's not the case. So unfortunately, if they have PCO, they're going to have something done. So, but the ideal there in that situation would be remove the lens, do a surgical removal of the PCO, and put in a new lens. So, glass eyeball. Okay, somebody asked if you had a piggyback lens, if that's ever a problem for dilating, and I said, no, it's never a problem for dilating unless it is a problem for dilating. So rarely, I've actually never seen this clinically, but I have had associate that I know, a friend of mine who did have this happen once, where they dilated a patient who had a sulcus-based IOL that was not optic captured. Patient dilated well, did the YAG, dilation wore off, and the optic got captured on anterior to the iris, which is a bummer. And that has to be surgically corrected. You could try to dilate them and then see, have them positioned funny or otherwise. But generally speaking, the only way to get this back into position is to surgically go in, dilate them, put it back, intraoperatively put myostat or myocol, which is a constricting agent, constrict the pupil around it, and then that is a patient that you would tell you don't get to get dilated again, or it would be a bad idea to get dilated again. So very unusual, wouldn't expect it. Brooke. So what we're looking at the cornea, and this is kind of like a sequential images. The top two are the day somebody had a YAG, and then the other ones I think are at 1 month and 3 months, as I recall. But any idea what happened here? This patient had a YAG when they came in. Not by me.
They yagged the cornea.
Yes, way to go. They yagged the cornea. So I have seen this once.
So that's just like an inflammatory response there, or is it a scar?
It's an energy response to it, and it will usually fade with time. And I have seen it once before when someone else did it. And it usually just fades with time, but it's quite alarming when it happens. And when you're doing a YAG, you'll have focusing beams, and you would think it'd be really easy to just make sure that you're focused on the IOL and not the cornea, but there are enough case reports to say that it can sometimes be confusing. So again, just a point to make sure you're focused on the right area. The good news is this actually, like an IOL pit, looks very visually surprising at first. Will usually just fade with time and not cause any issues. The top right photo, you can actually see if it's really anterior where the energy was delivered, they could even have like some epi stain or uptake if it were to happen.
Interesting.
So no yagging the cornea. Okay, and then this is our unstable lenses that we were talking about earlier. So these are all lenses that I've seen in Montana over the last 2 years. I think these were ones I just found pictures of. Dislocated one-piece lens with the whole capsular complex dislocated. That's the top two. So the whole IOL and the bag complex are dislocated. The bottom two are great examples of a three-piece lens that's sunsetting or dislocating, but the bag is actually kind of central. So usually that's a sign somebody had a posterior capsule tear during surgery or a zonular weakness during surgery. Lens was put in the sulcus, but the sulcus support isn't holding the lens, and that lens is shifting. And these are patients that you definitely want to be a little hesitant to laser, because again, if you laser them, you could end up with an aphakic patient that you have to do a Yamani. And then the last one, this is not commonly seen. I'll throw this to any panelist that knows the name of this. I've seen this once in my life. Really unusual. So this is a one-piece IOL. The capsular bag is just kind of slowly starting to dislocate along with the lens, but the capsule is totally pristine and clear. There is not any remnant inflammation in this bag or capsule. It just looks totally, totally clear, but the whole thing's kind of shifting. I don't think any of you have seen it, so I'll just jump to it. This is called dead bag syndrome. So there's descriptions of, and it's usually seen with a one-piece IOL, and it's not really well understood, but there's literally like no inflammatory response to the capsule healing around the IOL, and this can show up 10, 20 years down the road, and the whole capsular complex along with the lens will just kind of disintegrate, or sometimes the one-piece IOL will actually, the capsule will get so thin it'll just cut through the posterior capsule and the lens will dislocate spontaneously. These are usually patients that have to be explanted and then have something done. So not a yaggable save, but sometimes can get questions about it if it were to ever come up. Travis, any questions on the YAG gland before we jump into SLT?
I think you covered it pretty thoroughly.
I didn't know if there was any like on the text thing.
Oh, no.
Okay.
No questions.
All right, sounds good. It's like, you're like, I'm good. I don't have any questions.
It's afternoon, it's after lunch, it's
Yeah,
after
I know it's
cookies.
hard.
I don't know people are.
That's why we had to have some fun
texting still.
pictures. Okay, so we're going to jump into SLT. And man, you were dying to talk about this earlier, Nick, and I just like
I was just
shut it
gonna
down.
Talk about it, but that's fine.
Yeah,
We're here
let's
now.
talk about, so I'd love to get your thoughts on SLT as primary treatment over drops and how you talk to patients. A newly diagnosed patient comes into your clinic referred for mild glaucoma, and they haven't started drops, they haven't done a laser, they're kind of asking you, hey, what should I do as first line therapy?
And I will answer that. I want to, because we ask this at the Fargo Symposium every year. We ask the audience. So
Oh yeah, let's do it.
you've diagnosed yourself with mild POAG or ocular hypertension, pre-parametric, you have no visual field loss. And let's say your eye pressure is 24 in both eyes. And would you, for yourself, would you do SLT? Hands for SLT. And then hands for starting a PGA or any other drop. Do we have anybody that would start? Yeah, we got a couple hands for drops. For my ocular hypertension patients, I do talk about the ocular hypertension treatment trial because I think that's important and why, should we monitor? Should we do something? Well, we should do something. So what should we do? Oh, I say you can treat eye pressure one of three ways: drops, laser, surgery, and now intracameral meds as well. But for mild POAG, I'll talk to doctors. They'll say, what do you talk to your patients? And they'll say, yep, I'll offer drops and I'll offer SLT, and we let the patient decide. And I just think right now the data behind SLT is too good to ignore. And we have all heard of the LIGHT study, and we had 3 years of the LIGHT study. And then they did a 3-year extension on the LIGHT study that came out in 23. And what was impressive about that was they had like 600, close to 700 eyes in the very first LIGHT study. And for the 3-year extension, 92% of those patients went into the extension, which we all do research and we all need to recruit for research. So I just think that's really impressive that they got 92% of those patients into the 3-year extension. So the LIGHT study now has 6 years of data. And in the SLT arm, 70% of the patients remained at IOP target or below. And in the drop arm, it's right there. Yeah, 27% of patients showed progression versus 19% with the SLT arm. And the biggest thing for me was that there's 2 surgeries I really hate signing people up for: tubes and PKs. Because the tube is, the surgery is the easiest part for them, probably not you, but the surgery is the easiest part. But we're gonna see you at a day and a week and a month and 3 months and hammer these steroids and cross our fingers the blood doesn't scar over, and then they're just something you do not wanna have to move towards a tube or a trab. Well, in the drop study, in the drop arm of the LIGHT study, I think it was like 36% of patients needed a trab. And in the SLT group, 13 patients needed a trab. So the data with SLT is too good to ignore. And I hope there to be a shift. Instead of when you first diagnose a patient with glaucoma, it's like a reflexive thought to prescribe a drop. And we've been doing that for years, where now I hope there's a reflex to send for SLT because the data's too good.
Yeah, I think that's super well said. And one of the things that Travis brought up when we were doing the glaucoma talk is it sort of is ingrained, and you oftentimes will hear even us say, or doctors say, or patients say, I'm just going to do a drop. It's safer and it's easier. And I think, on the easier part, it's not easier because they're not compliant. And on the safe part, this is where like the light trial, the 6-year data is like the most compelling data to say, hey, we should be doing SLT as primary treatment. You're twice as likely to need glaucoma surgery if we start a drop as opposed to start with laser. And you're 7% more likely to have progressive glaucoma changes. Those are super, super meaningful things. And so I do think, again, as you see ocular hypertensive or open-angle glaucoma patients, I would really encourage you to think proactively about SLT as a primary treatment. And again, much like MIGS, much like all the other things we talked about, like they still need to be followed for their glaucoma. They might need repeat SLT, but the data around it definitely demonstrates an improved outcome for patients who do SLT first as opposed to drop therapy first.
And you get a couple extra points if you do SLT as a primary treatment over SLT post prostaglandin.
Yeah, so I wouldn't, if I newly diagnosed a patient, I wouldn't start a PGA and send them. I would not start anything at all because they did demonstrate, usually a treatment-naive eye receives a little more bang for the buck on SLT as opposed to having been on 1 or 2 meds. And I'm still surprised with this study that like the quality of life scores were about the same for SLT and drops. But what was also there was the glaucoma symptom survey with the drop arm and the SLT arm, where obviously, redness, irritation, burning, stinging with drops, and visual complaints with drops were way higher with drops, obviously, as opposed to the laser.
Yeah, beautiful. And I think, again, you actually see this in a lot of the academies now recommending. So historically, that was never recommended as first-line treatments. Now, pretty definitively, a lot of the academies, glaucoma societies, and otherwise are recommending SLT as first-line therapy, which I think is supportive of the evidence that's out there. And we also know that it can be repeated. And even in a patient who's non-responsive, the other interesting thing from the light trial, patients who were non-responsive to first SLT treatment, actually about 75 to 80% of them were responsive to a second treatment. So just because somebody doesn't respond the first time doesn't mean they can't try a repeat. And there was a significant group of that patient population that did immediate repeat SLT and then was responsive the second time. So
When would you call somebody non-responsive? 1 month, 3 months?
yeah, I generally tell patients it's going to take 4 to 6 weeks to take effect. We usually recommend seeing them around 6 to 8 weeks. If they're not having an effect at that point, I think it's very reasonable. If you wanted to wait till 3 months, you can, but I think at that 6 to 8 month or 6 to 8 week follow-up time period, you have a really good idea if they're going to respond or not.
With repeatability too, if they respond well the first time, the chances that they're going to respond well the second time is super high. And we talked about how MIGS was a bridge between, drops and tubes, and now SLT I think of SLT as a bridge to MIGS. Yeah. And where, if I had glaucoma, where I would reserve drops is for, later in life. Because I don't love talking to my 80 to 90-year-old glaucoma patients about surgery. And they don't like that either. And even though MIGS are safe and it takes 5 minutes, I would rather bridge, if I'm in my 50s, bridge that time with SLT. Now I'm in my 60s, now I'm gonna have some stents. Now I'm in my 60s and 70s, because there's no glaucoma treatment that works forever. And glaucoma always fights back. And so you can have somebody controlled with stents for 2 or 3 years and the pressure comes up, and they've tolerated drops for a couple of years and then the pressure goes back up. But I would rather take drops later in life, because I don't love the idea of surgery when I'm 80, 85, 90. And that's where I would rather use drops. However, if you use them earlier on the disease, now they've developed a reaction to all of them and we can't. So it's a shame when, I have to sign these patients up for a tube because, well, they can't use any of the drops because they've already, their eyes are so red because of them.
Yeah. Mechanism of action, we just quickly review. There's kind of debate as to actually how SLT works, but you're basically targeting the pigmented trabecular meshwork And the thought is you're getting a cellular response either by cytokine release or macrophage recruitment that changes the architecture of the trabecular meshwork to allow it to drain better, which is why it's also able to be repeated. And when you're doing SLT, if you're doing indirect SLT, you'll classically see this what we call champagne bubble sign, which is sort of what you titrate the energy level to, where you're seeing a responsiveness to the tissue application with SLT. Can you talk through maybe just a little bit, Sierra, as you think about SLT indications? Like, is there patients that you're hesitant to use it in, or what patient populations are you most commonly recommending it in?
Not many that I'd be hesitant to use it in. I would say normal tension glaucoma is probably going to get a little bit harder to see a good response out of. If they have a history of inflammation or anything like that, then I'd be nervous about that. And obviously, if they don't have open angles, then can't see the trabecular meshwork. But not very many scenarios where I would be nervous or recommend against it.
Perfect. SLT procedure, again, we just lost our confidence slide, but that's okay. So SLT procedure, this is a lower energy delivery. It's a 400 micron, so a wider diameter spot that you're delivering it in. And typically, I usually start around 0.7 millijoules, but you can titrate up or down. The more heavily pigmented an angle is, the lower the energy typically can set because you're going to get greater absorption. The lighter pigmented a trabecular meshwork is, the higher energy that you're going to need. And then the other thing that I would just say as a kind of point of information is, if you start doing SLT and you're doing indirect SLT with a gonio lens, I typically find starting with the nasal or temporal angle is a nice spot. The inferior angle, so if you're looking through the superior mirror at the inferior angle, is the most pigmented. So if you have a very lightly pigmented person that's hard to identify their angle, you can start in the superior mirror. But if you have somebody with moderate pigmentation or they have pseudoexfoliation or otherwise, they'll oftentimes have a super prominent Schwalbe's line in their superior mirror looking at their inferior angle. And so sometimes if you're starting there, you're like, oh, is that Schwalbe's line? Is that highly pigmented trabecular meshwork? Where do I want to be at? And so that's where sometimes starting nasal or temporal can give you a little better angle anatomy to then be able to go around. And you can do this in patients who have had previous stents. You're just not SLTing right on the stent itself. Next thing I just wanted to hit on was direct SLT. So traditionally, we've always done indirect SLT. We now have the ability to do direct SLT. Direct SLT, for what it's worth, again, we're delivering the energy. And I'm going to play this video. This is actually one of our previous fellows, Brian Schaefer. And it just shows you, not that I dislike SLT, but man, direct SLT is quite nice for patients to go through. So we'll play this. Ooh, that's even comes with fun music.
Little pressure on it.
So you put a little eye speculum in, similar to like if a patient was to have an injection. They move forward. This auto-detects the patient's limbus and then delivers the energy. And the energy delivery is just in a couple seconds, as opposed to a minute, 2 minutes of kind of monkeying around with the lens that's on their eye. So they're stabilized. You'll hear Brian talk about once he gets it registered.
It's going perfectly. Don't you worry about a thing.
So they're turning the lights on. This is the activation of the laser.
We are already done.
And then it's done. And the patient sits back. So the actual laser treatment itself is just a couple seconds, which is kind of a new fun area. And I'm going to throw this one actually to our Fargo colleagues, because you guys have direct SLT in your clinic now. There's been some nice studies that have shown similar efficacy between direct SLT and regular SLT. Can you maybe, Brooke, can you talk about the patient experience with direct SLT, what your guys' initial impressions have been so far?
Yeah, the patient experience is really nice. In fact, our patients don't even sit down. They literally walk in and put their chin in the chin rest, and then they sit back. It is so fast. I've watched Mike do a few of them, and I don't even know if we use the lid spec, because that's how fast it is. But I'm assuming we must, so that it can detect, like basically, the surgeon will see the eye on the screen, and you kind of tap around it, and it identifies the limbus, and then once we're happy with the identification of the limbus, you basically hit fire. The patient comments on like a warming sensation, not necessarily burning, but so I usually just let them know that they'll feel a warming sensation for 2 or 3 seconds, and that's it. So it's very, very fast. I would say it's far better than having to use a gonio lens to do indirect. So very good patient experience.
And a really nice procedural experience from a provider standpoint, having not done it. but it's way nicer on your neck and otherwise. The other thing that I would just mention from a side effect profile, the one thing that we do see more commonly with direct SLT than SLT, very safe profile otherwise, but sometimes they will get these kind of petechial or punctate subconjunctival hemorrhages kind of at the perilimbal region. About in the clinical trials that they did, maybe 1 out of 5 patients experienced that. Micro subconjunctival hemorrhages go away very quickly, but some patients will sometimes notice that. So, any other questions or comments about SLT before I jump to LPIs?
We did have actually one question before you start that. It was, I believe it was actually back to YAG, but it came in after you started SLT. So any tips for capsulotomies on fibrous membranes?
Yeah, so if somebody has a really fibrinous posterior capsule, and again, the most common time we'll see this, somebody with large history of really bad uveitis, or most commonly somebody who's had a really bad retina history. So maybe they've had multiple retinal detachments, they've had silicone oil placed, the silicone oil is removed, but they'll oftentimes get this kind of leathery, fibrotic posterior capsule. The biggest thing in that setting is you're just often going to have to increase the power of the energy, and you're going to have to increase the number of spots that you're doing, and you'll oftentimes have to do them closer together. But yeah, the bigger thing is just you're almost always going to have to increase the power. And so that's one of the few times where I'll go up to 4 millijoules or higher is in a really fibrinous posterior capsule. Rarely you'll see this kind of fibrous response of the anterior capsule where you get what we call capsular phimosis, where the front part of the capsule will start to scar down. And in that setting, you can also still use a YAG laser. We do an anterior offset. You actually don't need a high energy, even though it looks pretty fibrinous. You can drop the laser energy down to 1 or 1.5, and you basically just make small little kind of cruciate openings, and kind of usually start with 4 at the cardinal directions, and then add 4 more intervening. So you kind of have 8 little spots that kind of break up that contracting membrane and allow the lens to kind of sit in its normal position. It looks rather unusual afterwards if you dilate the patient. Visually, it's outside of their scotopic pupil, so it's not bothersome to them, but it can look a little unusual as you look at it the next time. LPIs, so laser peripheral iridotomy, most common indication for angle closure of some form or fashion, whether it be chronic angle closure, acute angle closure. Sometimes we'll use this for a plateau iris as well to try to change the position of a plateau iris, and or prophylactic in a fellow eye that had a previous acute angle closure in a rather narrow eye. And again, in this case, we're directing the laser energy, the far peripheral iris, avoiding any marginal vessels, making a small opening through the iris to allow aqueous that was previously trapped posterior to the iris to have an easy access to the angle and decrease the risk of them having an angle closure event. LPI contraindications, inflammation or neovascularization would be the big one. Interestingly, sometimes we have a patient who has a long history. We see a lot of, uveitis patients in Billings that are being followed by a uveitis specialist, and now they have an occluded pupil and their angles are narrowing. You can still do an LPI in that setting, but we'd love their eye to be as quiet as possible. If their eye is inflamed and you have to do it because their pressure is really high, you just have to pound them with steroids, or the inflammation will just close off the LPI opening that you just made. So that's kind of the big thing with that. The LPI procedure, again, we use the same YAG laser. We're typically increasing the laser power, and this is also one where we'll oftentimes do a lot of modern lasers. You can do like a dual or a triple shot. So it'll deliver, if you're at 4 millijoules, it'll do 4 millijoules sequentially really fast in a microsecond pattern that can help break through really nicely. If you had an argon laser, historically people talked about using an argon laser in heavily pigmented irises first, followed by the YAG. In all honesty, with a modern YAG laser, we just use the YAG without pre-treating with argon, and patients do very well. Show of hands from the panelists. If you were having an LPI, would you want it superior, nasal, temporal, or inferior? We'll just go across, and you get to say which one you would have. Go.
To me, it makes sense to do it superior, but I know data says otherwise.
So where would you have it if it was your eye?
Superior? I don't know.
Okay, don't believe the data.
I don't want it.
Okay, all right. Alicia,
deep anterior
where would you have it on your own eye?
Superior nasal.
Superior nasal. Oh, that's tricky. You kind of made your own answer.
I
Okay.
did my own.
Sierra?
Nasal.
Travis?
Again, logically, it makes sense superiorly. You think the lid's going to cover it up, so you have reduced potential for light passing through. But I know it's on. I'm pretty sure the answer is on the horizontal. So she said nasal. I'll go temporal.
Nick?
Like 9/30/10.
Well, wait, right or left eye? Because that would be nasal or temporal, depending on the eye.
Well, point at my left eye, which would be left eye.
Superior
Looking at
nasal.
It'd be like 9/30/10.
Okay, sounds good.
Yeah.
Interestingly, historically, it was always the rule of thumb was superior. Then there was data that came out that showed maybe on the horizontal plane actually did cause less photopsias for patients. Most of the meta-analysis have shown that it's probably a similar rate of dysphotopsia. So, like some of our glaucoma, when we go to like our glaucoma days and people get very esoteric about it, some people have very strong opinions, but the data actually shows that whether it's superior nasal, temporal, probably not a huge difference. We very rarely do it inferior, except in one situation. Where might we do it inferior, Alicia? Quiz question. Or you can phone a friend to your left with Brooke.
When are we doing an
Inferior PI.
Oh, DMEX.
Yeah,
D6.
great. Yep. So if we're doing a partial thickness cornea transplant where we're putting in an air bubble, we'll proactively put an inferior PI so that as that air bubble is going away and their pupils occluded, they still have a pathway for aqueous to flow through. So that's the one spot where you might say, well, why in the heck did Alicia Russell put an inferior PI on this patient? That doesn't make any sense. They definitely didn't tell us to do it there. That's usually the case, that it's a patient that's had a partial thickness cornea transplant. So the two studies I just quickly wanted to highlight, the ZAP trial. So the ZAP trial was looking at LPIs versus observation in patients with narrow angles trying to prevent angle closure episodes. And what it showed was overall the incidence of primary angle closure was lower in patients who had a prophylactic LPI, but the number of patients needed to treat was very, very high. So actually, patients with just narrow angles actually didn't often go on to developing primary angle closure, but there was a statistical improvement in doing an LPI versus observation. The more important study that I think has really gained a lot of traction is the EAGLE trial. And what the EAGLE trial said was, okay, what about those patients with angle closure, glaucoma? Do they have better outcomes if we go straight to a clear lens exchange, even if they're pre-cataract, versus doing an LPI? And the data is very definitive on that the cost effectiveness, quality of life, number of treatments needed was lower in the clear lens exchange group than in the LPI group. So if we have a patient, in their 50s, 55s, 60s, very narrow angles, presbyopic, we'll certainly talk to them about, hey, the most definitive treatment for your narrow angles and your configuration is going to be to remove your anatomical lens. Their anatomical lens is 3.5 to 4.5 millimeters thick, and when we remove that, we'll replace it with a 1 millimeter thick IOL. And so that's naturally going to open up the drainage angle, the best 360 degrees circumferentially over just an LPI. And there were still some patients who required LPI post-clear lens exchange, but there was a far lower percentage of patients who required dual therapy. So I do think if you have a very hyperopic, anatomically narrow patient that you're concerned about angle closure, the data would say that patient is certainly not someone who should wait till they have 3 to 4 plus NS to have their cataract surgery. They should have it very early, 1 to 2 plus, or even before they develop a cataract if you're worried about angle closure.
We still get some referrals in Fargo for LPI. I think what that study showed was that you need to do 47 LPIs to prevent one eye from going into angle closure. So if we're going to do an LPI in every narrow angle, we are over-treating everyone. So yeah, we don't really do LPIs for just a narrow angle anymore.